Esteemed colleagues, I'm asking you to take your seats because we are starting our work. Now, the first plenary session of substance that we're going to hold in the framework of the 6th conference. You all have the program, but I'm going to name it Ending the HIV/AIDS Epidemic, Overview Achievements and Lessons Learned. I want to introduce the speakers of our plenary session. First of all, these are the First Undersecretary General, the Acting Deputy Executive Director, Tim Martino, Mr. Gottfried, who is the Director of HIV and Hepatitis Department, the Co-Chair of AIDS 2018, the Professor of the Amsterdam Medical Center, Peter Rice, and Alexei Tsoi, the Vice Healthcare Minister of Kazakhstan, and Natalia Zhukova, who's the Deputy Healthcare Minister and the Chief Sanitary Doctor of Belarus. You all have your handouts, and you all have the draft of the final document. So I would like to call upon you during the 6th conference to focus on working on this document so that at the end of our 3 days conference we would summarize come up to some pragmatic, thought out goals that we need to achieve within the framework of political decisions of our governments of our countries, which were made during the special session of the United Nations in 2016, and this is to expedite the struggle against the HIV inspection and stopping the spread of this infection by 2030. The organizing committee laid out a very good foundation for our work, so I call upon you, please work on these final documents, all of you. At the beginning of our work, I would like to announce the numbers, the results for the participants in our conference. The registration as of today shows 2,937 participants. It's more than in 2014, 2016. It's in order to say a few words about the gender composition. In 2014, we had 62% of the representatives of the fair sex. Now the ratio is 57-43 correspondingly. The number of participating countries at our conference is 63. This time we have a lot of grants. It used to be 300, 625. This year we have 700 grants, 700 stipends for the participants. We have 82 events during the conference, 5 parallel sessions, 456 speakers, which is twice as many as in 2014, which proves that our conference, the 6th conference, is gaining more and more content, because the discussion, the subjects that we're discussing, even taking into consideration the number of speakers and the parallel sessions. Still, it doesn't cover all the subjects, all the topics that we need to discuss. We have 212 international experts, and you'll have the resume that will work towards the contents of our conference. Now, we have 15 minutes for every speaker for his or her presentation. So I would like, first of all, to call the the first speaker, HIV response in East Europe and Central Asia, Anna Popova. Esteemed Presidium, esteemed participants of our session, of this first plenary session, we've heard very important words during the opening ceremony, and of course the success in coping with the global problems of healthcare, including HIV/AIDS, it is driven by many facts, not only professional, social, financial, and others, but no matter what the circumstances are, we need to keep the goal in mind. Our duty as doctors, as the civil representatives of the civil society, as the organizers of healthcare, is to ensure the well-being of people. And in all regions of the world, people hope to keep their health, and we cannot rob them of this hope in spite of all the political situations. The devotion and commitment to our case allows us to believe that we'll achieve success. HIV, AIDS is one of the acute problems in the world. There is not a single country which managed to stop the spread of the epidemic or curb it. The goals are all outlined within the framework of the UN AIDS. And speaking about sustainable development, as Gennady has just mentioned, one of the tasks by stopping AIDS and TB by 2030 is one of the most. We want to have the decrease in mortality by 95%, TB by 90%, and the 1990 goals are well known to everyone present here. But the success of stopping the spread of the HIV infection in the world, they are present, and you can see them in the slides. I'm not going to read the numbers that are here on the slide, but at the same time, this success doesn't prove that we have covered midway, because in any case we are still very far away from the final goal, and there are some examples of that. Speaking about the numbers, then the global statistics on HIV gives us these numbers that you can see on the slide. That when we detect over 1 million new cases and 190,000 are children, TB is one of the main causes of death in HIV people, and the greatest concern is the spread of TB, is the multiple drug resistance TB strains. The global goals have not been reached in spite of all the efforts. The spread of this epidemic is continuous. The new cases appear every time, 11% as compared to the previous year. The projections, which were really very hard for Russia, did not come true, because it was expected that we'll have 5 to 8 million people with HIV infection. So it gives us hope, but at the same time we need to move forward. What are the steps that we're going to make? First of all, the strategic documents in the countries of this region. The final documents that were adopted in 2016 made the total conclusions that for sustainable development, we need the next 5 years, and the investments need to be raised. We need to implement national measures for comprehensive opposition to the HIV spread, and of course it is not possible without the consistent efforts of all the states. New strategic documents have been adopted in many countries. You can see them on the site, in Armenia, Tajikistan, Kyrgyzstan, Kazakhstan, the Russian Federation, which adopted a federal program to end the spread of this infection. And I also wanted to mention that the funding has been increased for diagnosis and treatment coming from the national resources, and the same in Belarus, Azerbaijan, and other countries.
So we have mentioned today several times that one of the main targets is to increase the coverage of testing of HIV tests. And I would like to say that in the recent years, the coverage has significantly grown in Russian Federation and Kazakhstan, Uzbekistan. And at the same time, I would like to underline that there is some challenges with having access to the tests. In Armenia, there is around only 0.6% of coverage, 6.8 in Tajikistan, and we believe that in the near future we need to significantly raise these figures. Another important thing is the availability of therapy in the region. According to the data which were given by the countries to us, in 2017, more than 60% of HIV-positive people who knew about their status received therapy in Azerbaijan, Armenia, Tajikistan, Kazakhstan, and in Kazakhstan, the coverage grew by 23% versus 2015. In Uzbekistan, Kyrgyzstan, Belarus, in 2017, the art therapy coverage was around 53.5 up to 55% for all people having HIV positive status. In a number of countries, the cost of annual treatment has been reduced. That's true for Belarus, Kazakhstan, and Russia. So we have heard the representatives mentioned that today. Part of ARVs include combined medications with certain dosage. Another important thing which prevents HIV propagation is, of course, raising awareness. And we believe that this is a highly efficient tool that we can use as part of our effort, and it's definitely part of the strategy that we can apply, especially to those who have been diagnosed with HIV. In order to motivate population for voluntary diagnostics, large-scale IT campaigns have been launched in Belarus and Armenia. These are the countries which for the first time have launched the program about self-test about HIV, which is using oral fluid. And special attention is paid to various information technologies which are enjoyed by younger population. A lot of campaigns are being launched through these sources of media. The regional countries have also increased the coverage on key population groups, including drug users and prisoners. And these results are showing their positive effect. As for migrants and their families, more than 1,000 of people have been educated and have been launched to support various camps where the migrants are also involved and are being educated. As for prevention of HIV, the outreach programs are being underway in Armenia. New internet technologies are being adopted, which increase engagement. Mobile apps allow to track the assessment of how HIV-positive kids are being treated. A number of practices which is aimed at providing social support to HIV-positive people using multidisciplinary teams which involve medical specialists, consultants, which leads to better efficiency and also suppression of viral load for more than 70% of participants. UNAIDS initiative has set up a program which involves, for example, young designers and fashion aids companies that engages young design specialists in Armenia, Tajikistan, Kazakhstan that can work on a red accessory that symbolizes HIV response measures. So the unified epidemiologic space based on information system and synchronizing prophylaxis measures, running joint scientific research, reinforcement of human resource pool, and implementation of bilateral programs. So all these are parts of the main objectives that are needed in order to tackle this challenge. Another important stage towards our response to HIV is the strategy which is called HIV response in Russia, and we believe that this is a really crucial stage of the overall strategy, and the plan has been introduced in 2017. The main goal is to prevent propagation of HIV. So the main objectives are here on the slides, and we need to focus on them. One of the components of this strategy implementation is to improve legal and regulatory framework. And for this part, we have made amendments to a number of federal laws that regulate migration and which significantly simplify the access and life of migrants in the Russian Federation. We have also made amendments to the laws which regulate the activities of NGOs. And once again, I would like to call to action the NGOs. We have a number of programs that are available for you and that can support you greatly. And another example, information campaigns. I'd like to underscore that we're very much focused on them. And a special focus is laid upon younger and student audience. Also on our work with industrial companies. Starting from 2016, a consolidating effort about raising awareness about HIV was undertaken by the Foundation of Social Initiatives, which is led by Svetlana Medvedeva, and the All-Russian action, which is called Stop HIV, Stop AIDS, which will be held for the second time this year. And more than 2,500 of points where you can voluntarily run a test on HIV have been hosted. And Kazan, a marathon which is called Test Yourself, has been arranged, and more than 3,000 people participated in them. Hotlines were arranged, and in 2017, Rospotrebnadzor has arranged more than 100 hotlines and more than 1,000 of counseling sessions for the audience. Raising awareness, and by the way, young forums that involve young specialists always have a session or a dedicated component which is devoted to HIV issues. Last year, 23 fora were involved at every level, federal and regional and municipal level, and at every level we do have a voice, we do have someone who speaks out about that. Support of major companies, for example, Sibirskaya Coal Company, they do have an action plan and a number of activities about programs that are targeting the workers who work at coal mines in different constituent regions of Russia. Another part that was arranged by Russian railroads. They do run a number of very productive activities. I would like also to mention Rusal and other companies that do so. Another important event which I would like to highlight involving school children and students across all Russian education system. This is very important. So partnership among civil society representatives and educational institutions, socially focused NGOs. This is really important for any nation, including Russia, of course. The projects that provide palliative care and support and treatment for HIV people. Right now, Russian NGOs work in the area of social support to families, and they are supported by presidential subsidies. In 17 regions, the NGOs, with the help of international donors, are expanding the access of key populations to treatment, to diagnostics, and to tests. We also need to underline the results that we have achieved in Russia about development of ARVs. And as part of Pharma 2020 federal program, 27 medications have been are now being produced. They are produced by 10 Russian pharmaceutical companies. We're also localizing manufacturing and completing transfer of several international technologies. And in sub-Moscow region, a last generation ARV is going to be produced soon. Right now we have 26 ARVs registered in Russia, which we are actively using. In 2017, the list of significantly important medications included 83 new medications, protease inhibitor, which is recommended by leading international protocols. Also, the treatment reduction has been applied by 50%. Another point that I want to mention, the activities that are aimed at creating advanced new medications which are run at the platform of the Center of Epidemiology. Absolutely new medications have been applied for molecular vaccination and genetic-based medications. Dinavir, who is right now approaching clinical trials phase. In order to improve professional qualifications of medical specialists in the area of comorbidities, in the area of selecting the better treatment strategy, the specialists are of this Central Scientific Institute of Epidemiology have run 83 training workshops and webinars, which covered more than 5,500 specialists from different Russian regions. But on top of that, of course, challenge is still here. Insignificant lack of therapy and a number of other challenges. So still the cost of treatment still remains at high range. Also lack of combined medications and art, which is being included or which is being given to the HIV positive people at later stages. So a number of challenges are still here, and I will be really interested in discussing them later today. As for diagnostic medications, so right now our country produces more than 40 types of various diagnostic tests. Our products are also registered in Belarus and Kyrgyzia, Uzbekistan, Ukraine, Korea, a number of European countries, and are being used there very actively. Our national companies produce more than 20 reactive agents to define TB molecules. Scientific research, another huge part of our job, a very important one. As part of this research, we constantly monitor the resistance of HIV to ARVs, and this monitoring has been launched in 6 member countries, And before our first plenary session, I talked with high-ranking representative of WHO, with René Minhoy. We talked with him about how we can arrange our cooperation in terms of implementing this project involving WHO. And I see that interest to this program is really high. In 2017, on top of routine monitoring, Russia has done the analysis of primary medicative resistance, and this data is being accounted for when we develop annual recommendations on HIV treatment. And here I'd like to highlight once again that we are producing this recommendation every year. By behavioral research among key populations have been done in 7 regions: Yekaterinburg, Kemerovo, Krasnoyarsk, Perm, and Tomsk, and Moscow. And the obtained data shows that HIV continues to propagate among key populations due to unprotected sexual behavior. Test coverage is one of our goals. This slide shows the dynamics. So we are working on that. We do have positive results, and I'm sure that our continuous effort will achieve high result. Compared to 2012, 2012 versus 2017, we see the growth by 30% of HIV test coverage. And this slide shows also the growth rate from 2007, the number of HIV positive people who receive ART. So right now, almost 50% of people with HIV positive status receive antiretroviral therapy. So in 2012, the HIV growth rate was around 13%. 2017 is only 2%. So we are moving along the correct path, but at the same time, a lot of challenges still persist. So let me highlight that the amount of adolescents between 15 to 20 years of age have been reduced to 1%. Younger people between 20 to 30 years have also dropped to 20%. Our aim is to get to 0% for these populations. So the results are obvious. They are here before you. But at the same time, I'm saying it once again, that we understand the amount of challenges which is still in front of us. Russian Federation continuously develops the multilateral cooperation, and there are several components here: political commitment, development of agreements, implementation of joint projects and programs, and arrangement of discussion platforms. Russian programs of supporting international development were supported by more than $470 million in 2017. On top of that, several billions rubles. The program of technical support to Russian Federation between 2012 and 2018 as part of the national policy, which is aimed at fostering international development, that was signed by presidential decree back in 2014. We will continue helping the countries of Eastern Europe and Central Asia, similarly to African countries and other Asian countries, in terms of preventing infection-type diseases. Since 2012, we have successfully implemented 13 projects, and the recipients of Russian support were 15 countries. We have supplied advanced lab equipment, test system, and immunobiological medication of Russian-produced vaccines, portable mobile labs, and diagnostic complex. Right now, we continue implementing the projects in 10 countries, in 10 foreign countries. Our program to help Central Asian and Eastern European countries. What is the program? So I will go fast through this slide. Several phases here: research and scientific activities, development of software, involvement. Armenia, Belarus, Tajikistan, Kyrgyzstan are involved in the program. Research activities are done in directions and 5 streams jointly with national companies of member countries. In 2012 or 2015, there were various programs which were also aimed at personnel and medical staff training. 9 mobile clinics have been given to countries in order to provide support to the populations. Over 2 years, more than 620 services have been provided. 620,000 services have been provided to the countries. So what does it show? It shows that we can continuously work even if reduced financing from international foundations is being allocated. Our regional successes and regional problems is our regional responsibility. And at this conference, we will be discussing not only prophylaxis and prevention of that, but we will be discussing the results of most advanced research, most recent discoveries, and due to the point of fact that this topic is highly topical and highly acute, I would like to once again talk about the measures that are being implemented by the countries, and based on the specific of each country, in that we need to work on that in order to customize the measures so that we can reach the objectives by 2020 and 2030. So there's a lot of things for us to do. The dynamics of our activities, the dynamics of our movement should be accelerated. We should no way stop. We should go ahead and we should apply every effort in order to be efficient. So what do we want to propose to you today? Keep the commitment. Keep the commitment in terms of continued response to HIV in Central Asia and Eastern Europe. Keep on implement the programs and response strategies based on scientific foundation. Financial support, really important thing. We need to continue provide funding to a set of activities that would prevent HIV infection in Eastern Europe. Access of migrants to prevention programs, to diagnostics and treatment. We need to reinforce the intergovernmental, interministerial, and interreligious cooperation. We need to provide for implementation of comprehensive strategy that are evidence-based, that are state-of-the-art and advanced. We need to reinforce national and regional surveillance systems and to continue promote awareness about epidemic, provide for equal rights and equal access, available access to test, diagnostics, and treatment using newest technologies and express test methods. So I hope that this conference will call to action and will answer many of these questions. Thank you.
Thank you, Mrs. Popova. Esteemed colleagues, I've been listening to this presentation and I remembered our beginning. The first was in 1980s when we first encountered this infection, and the recent ones. I have an impression that we are sort of trying to close ourselves in our medical community, though our strong side has always been the synergy of all the agencies, all the stakeholders, including the penitentiary systems and the force agencies, because we need to all face this huge social problem, and the primary prophylaxis, and I repeat, we've always been strong in that. We need to reflect it working on this final document. Though, of course, we started using some military terms like the angle of attack and so on. We are becoming militaristic, though, of course, our nature is totally humanitarian. But let's not forget that we have huge reserves, interagency reserves synergetic reserve. Now we are going to give floor to the acting Deputy Director, Program Branch UNAIDS, Mr. Martineau. Global response to the HIV epidemic in the world. Welcome.
Are we on? Okay. Thanks. Let me start by thanking the chair for the opportunity to speak, and also to Dr. Popova. It's her presentation just then. It highlights the reason why we always ask countries for information, for examples, and for data. And there's a lot of rich information there that's extremely helpful to us as we move things forward. Thanks to the rest of the panel and obviously the participants here in the room. It's great to have an opportunity to talk. The question I've been asked to sort of try and do in 15 minutes is really to speak about the global response, and trying to do so in 15 minutes is a little bit of a challenge, I have to say. It's one of the most, well, it is the most significant global health program in the world, and looking at that, there are both positives and negatives to what has been achieved, and many complexities that we need to get into. So I've started, is that working? Where do I point this to? Do I just say next slide, please? Rather than pressing a button? No? There we go. Thank you. So I thought I'd start with a little bit of a positive message here today, and look at some of the success around treatment. This is obviously a fantastic collective success that we now have probably 21+ million people on treatment around the world. There's enormous global variation in that figure, but it is a testimony to what can be achieved when you have strong political leadership, some financial resources behind you, and a very serious commitment to achieving results. No, next slide, please. Okay, thank you. So this reflects where we are in terms of progress towards the political declaration target. We had committed to putting 90% of treatment, 90% of people on treatment by 2020. We are on track to achieve that target. And I wanted really just to highlight a few things that I think are important within the context of that success and how it's being achieved. One, and I can't stress this enough, is I think the importance of community engagement, both in terms of policy and in terms of delivery of programs around the world, particularly as we try and reach that final target towards 2020, reaching populations that are most hard to reach. We really need to engage with civil society in doing that, and looking to them to work with us. So I mentioned sustained financing as an important issue. I think the other thing that is significant within that curve is that there has been a flatlining of resources over the last few years, but we are still managing to drive improvements in the program and efficiencies within the program that enable us to continue to reach populations and to provide them with services. Now, I'm not sure if it's this working now, or it is. Great, thank you. This is a little bit of a complicated slide. I think our communications people like it, but let me take time just to explain it a little bit. So the green dot in the corner there is the number of people on treatment in 2000 in South Africa. The yellow dots are the number of people on treatment now in South Africa. And we like this slide because it points to the kind of turnaround that you can achieve when you have a real serious commitment and leadership. And Michelle, UNAIDS Executive Director, spoke a little bit about this within the context of the President Putin's statement around TB and what can be achieved with that kind of strong drive and the importance of that. And we think we can do this within the Eastern European region as well if we put serious effort, serious commitment behind that. It takes creative thinking, it requires different ways of delivery and a whole series of challenges, but it can be done when you have a whole of government approach and seriously engaged in the program. Obviously, it's not just treatment. Prevention is also an important aspect of the response. And this is actually a slide from St. Petersburg, and it looks at comprehensive prevention programming and the kind of declines you can have in incidence of infections if you put together a program that deals with the needs of key populations, and whether that's condoms, whether that's needle exchange programs, whether that's behavior change communications, face-to-face work, harm reduction programs. These are the kind of successes that you can have in terms of impact on the epidemic. I wanted to put this slide up. We'll move on to some of the sort of gaps and opportunities in the future. I think it's an important slide. It's a very simple curve, but it actually speaks to a lot of people around the world. We now have 35 million people who have died from HIV, and we should not forget that. There continues to be 1.8 million infections each year. And it's a curve that we need to fundamentally bend at a faster rate than is currently the case. Otherwise, we will have a slow plateauing out and a continuation or an increase in the epidemic. So it speaks to a human crisis and tragedy as well as an epidemiological one. So what's stopping us doing better? Where are there gaps in the continuum in what we are achieving? I wanted just to point to a few key issues that we think are important. We still have nearly 16 million people who don't know their status, who are HIV positive. And when they do access testing, they are often coming very, very late into care. They are often very ill. They have very low CD counts still. And obviously their life expectancy as a consequence of that is compromised. Men are particularly an issue. Young men, with an approach that's based ostensibly on healthcare facilities, then often we don't access men. Men, I don't want to say more than this, but men don't like going to health facilities very much, and this is a chronic problem that we face within the response as well. And obviously there's a large number of pediatrics, and there is a global target for the achievement of pediatric treatment by the end of 2018 that globally I fear we will not achieve if we don't scale up treatment services for them. Sorry, I just jumped. There we go. This is the prevention target as opposed to the treatment target. And I think it speaks for itself. We're a long, long way off those goals that we have set for the community, the international community had set for itself. There's a number of fundamental issues here that we are not dealing with very effectively. As Michelle mentioned at the beginning, we have established the Global Prevention Coalition. We've been trying to look at a number of critical issues that we think could make the difference. Many countries do not have disaggregated prevention targets. Many countries do not have the appropriate capacity to deliver programs. Many countries are spending money on the things that won't make the difference. And if we are going to really achieve that little yellow dot in the bottom corner, then we have to find ways of significantly expanding and delivering programs to reach populations most at risk. This is a graph that flags new infection rates and change in new infection rates around the world. And obviously I'm sure we'll be coming to sessions throughout the next few days that speaks to Eastern Europe and the kind of things that we need to do to change that trajectory. It's not just Eastern Europe, there's some countries there in Africa where there has been progress. I can see Ethiopia there as a country that had great success at the beginning, and you take your attention away, you run a risk of the epidemic increasing. Shall I just stop working? There we go. Okay, just a little bit about risk of HIV acquisition. This is a slide from looking at key populations, men who have sex with men, people who inject drugs and sex workers, and just really highlighting the centrality of their need if we are going to change the nature of the epidemic. This is data that we've collected globally from different situations and the likelihood of infection, and needing to see them as key to all that we try to do. Similarly, on the treatment side, this is looking at 1990 in different populations and in different countries. We got 2 examples from India and also from Russia, and looking at the cascade, and there's a number of slides later on around the cascade as a useful way of looking at the program and where we are having success and where we are not. And the rates of coverage that we currently have are not going to change the kind of trajectory of the epidemic. We have to reach the kind of scale and ambition that we need to really achieve impact upon the epidemic. No, that wasn't me. Thank you. Thank you. Okay, this is about young women. I think obviously key populations are an important issue, but within the context of the global epidemic, this slide highlights some of the figures from for women in different parts of the world and the importance they have. I mean, we're encouraged that women are better at accessing testing, better at accessing treatment in many cases, but they still carry an enormous burden of the epidemic, and the risk for a young woman, particularly in sub-Saharan Africa, but not just there, is significant and profound, and something that we need to address through a range of programs to prevent the epidemic. And this slide really highlights the importance of HIV as a leading cause still of death among women globally, between 30 and 49, with tuberculosis there as another key aspect of that epidemic. Just turning a little bit now to Eastern Europe and Central Asia. This is the curve within the context of the region. There's been a 60% increase in infections since 2010. And it really is, it's the only region in the world where we're, there's some parts of the world where we're seeing a plateauing, and we have a concern there that the epidemic is not declining. We certainly have a concern here in Eastern Europe that this curve is heading in the wrong direction, and something we need to address. We haven't got broken down data within the presentation here for different countries, but I think it's noticeable Russia within that context. South Africa, Nigeria, and now Russia are the countries that we are most concerned about in terms of new infections. This speaks a little bit to the financial situation, again within the context of the region. You probably can't see it properly there, but there's been some good increases in domestic financing there. That's something that we do need to continue to build on. It's a great sense of commitment there that we're very positive and should build. But obviously it's still a big gap, and we need to obviously make sure that the money that is being spent on the best places and the best ways of delivering programs. But a big gap to still be addressed. I thought this was a useful slide just to look at progress within the context of 1990. It looks at different aspects of service delivery, and as I say, it's a useful way of looking at the efficiency and effectiveness of programs and the way they're being delivered, looking at community delivery most importantly as a means of program effectiveness and impact. You could apply this to any region, but there's a lot of lessons we can learn from this approach to program delivery. Just looking at some of the determinants of where we see success, and some of the things that we need to deal with in terms of programming. Data is obviously extremely important. We emphasize an approach that we call location and population. This slide looks at data from Atlanta and Windhoek in Namibia, but again, it's making sure that our programs are really reaching the people most in need in different parts of the world. And you could apply this in Washington, D.C., you could apply this in London, you can apply it around the world. It is about the need for finely tuned, disaggregated data at a local level, and then subsequently reaching the people most in need. I wanted to put this slide up just to, in terms of determinants and the importance of violence and discrimination. It's a slide that speaks to the risk of intimate partner violence for women, and not surprisingly, the profound impact that has on their health, both in terms of low birth weights, risk of HIV, other sexually transmitted infections, alcohol, depression, and suicide. And these things are reinforcing and increase the risk of HIV and other health conditions that we need to address and find ways to ameliorate. Stigma and discrimination has been mentioned a number of times at the beginning of the slide. This slide talks about the impact that stigma has upon people's willingness just to go to a health clinic. And if you're not going to a health clinic, you're not getting your HIV status checked, and you're not getting your treatment, and you're not getting your prevention services. And I'll come later on to the importance that we place on training around stigma and discrimination, most particularly for healthcare providers. Criminalization of key populations is also a barrier. The slide here talks about the number of countries that continue to have laws that limit access to services, and there was a useful piece of data just released yesterday around the impact that has, and this is a very basic level of impact where in Cambodia the abolition of brothel-based sex workers has resulted in significant declines in condom use, and these things are just basic steps that make a difference to prevention services and treatment services, and things that we need to think through carefully before we move forward. They have a significant public health impact. Speaking of public health impact, this slide really just tries to highlight the relationship between discriminatory attitudes towards people living with HIV and viral suppression. And viral suppression, in many ways, is the sort of the benchmark for whether we are using treatment to have an impact on the epidemic. And there is a quite clear line there between reductions in stigma and discrimination and improvements in viral load suppression, which just makes a strong case, I think, for continuing to address these issues. Finally, on these points, just a slide here on some work that we've done looking at the simple cost of homophobia and looking at its impact in terms of the GDP. I have to say I'd need to get the papers to be able to circulate those and share them with you more, but it's an interesting piece of work that tries to interrogate that issue a little bit further. Finally, I just wanted to talk about TB on this part. At the high-level meeting in September around TB, that the WHO is obviously taking a significant and leading role in supporting, very much supportive of that, and the President's statements and support on this issue have been fantastic. But it obviously has a great benefit for us in terms of our work around HIV. It's a leading cause of death among people living with HIV. And obviously has significant health and economic impacts. Just to talk a little bit about solutions, I'm probably going on for too long. This slide talks about PrEP. Just 2 or 3 points. We need to be putting in place in countries around the world comprehensive prevention programs that have 5 key pillars to them as appropriate to the epidemic that they have. Comprehensive programs for key populations, comprehensive programs for young women, and then looking specifically at condoms, PrEP, and voluntary male medical circumcision as elements of that response, and making sure that they obviously fine-tuned to the nature of the epidemic. You will only get significant benefits from the treatment programs that we are expanding around the world if they are balanced and approached alongside comprehensive prevention programs. But PrEP is an important new tool and an opportunity to strengthen those prevention programs. Testing is another area where we've seen significant progress. I think Dr. Popova put some good slides up about the increase in testing within the region. This slide talks a little bit about the need to differentiate and define strategies for testing that are most appropriate to the populations where you're going to get the best result in terms of people living with HIV. In this context, it's young people and the increased uptake around self-testing. We're seeing in a number of parts of the world a much greater willingness to get tested, a greater sense of confidentiality and readiness to access care as a consequence of that. This slide speaks to moving towards WHO-approved guidelines around treatment for all. As I said at the beginning, I think we're still struggling with in a number of countries with people coming very late stages in the disease for testing and for treatment. And we've seen a significant progress, most particularly in Eastern and Southern Africa, I think, where we are linking people once they have been tested immediately to care. And in an ideal world, they would be on care as soon as we have tested them, obviously with confidentiality and human rights in mind. But this is an ideal outcome that we would want to achieve. Stigma and discrimination, these are just a set of figures around countries that have done some work around training for stigma and discrimination. As I said at the beginning, I think this is a core part of the response. If we are going to have people accessing health services without fear, without concerns and without reservations, then systematically approaching stigma and discrimination and training on this issue is going to be key to success. Community responses, we believe, are an essential aspect of the future, not just in parts of the world where there is high prevalence. We see it around the world. These are some figures from Nigeria and Kenya, just demonstrating both in terms of cost effectiveness, better quality, and more acceptable service provision as a model that we need to try and work with and through as we build and then sustain these programs. Just going to talk a little bit about cities, because we think this is something that needs to very much be considered within the context of this part of the world. This slide speaks to a combined approach that looks at PrEP, it looks at testing, it looks at immediate access to treatment, and the impact it has on the red line there in terms of significant reductions in the number of new HIV diagnoses. And this, I don't know if you read some of this in the UK, it led to a whole set of complicated issues about who's going to pay for PrEP in the future, but it also highlights the impact that bringing these programs together closely has in terms of what can be achieved in terms of impact and new infections. Work we are currently doing within the context of a cities approach, large numbers of vulnerable populations based in cities. We've been working with them to ask them to commit to the Paris Declaration, which is around their commitment, mayors and city health authorities, to scale up health service provision for key populations and to look at the data within cities. These are the cities that have signed up to that agreement, and obviously we're working with them and partners. I think we might have EECAAC in the room here who are a key partner with us in taking that work forwards. Coming to the end, Chair, sorry about this, just three more slides. This looks at price comparisons. As I said at the beginning, getting effective, cost-effective first-line treatment regimens established, using TRIPS flexibilities, making sure that medicines are at the lowest price and best quality is essential. But also getting people onto care as soon as possible, because these first-line regimens will last longer and they will be more effective the sooner they are introduced. This is just a global slide. I won't speak to that. This speaks to the broader issue about the financial gaps, and we've talked a little bit about that within the context of Eastern Europe, but it's a global problem as well and something that we need to collectively address. I wanted just to close on this one final slide at the end. I think the response to the epidemic right since its emergence was through an approach that relied very much on advocacy around civil society and the centrality of human rights to the approach that we took forward. This is work that UNAIDS launched at the end of last year, just trying to reinforce that message that is the strength of the response and the best way forwards for the future. So I will stop there, Chair, and thank you very much.
Thank you very much, Mr. Martineau, for your very comprehensive report. It's always very interesting to see ourselves as compared to other regions in the world. And I would like to provide a couple of comments on your slides. First of all, you were talking about St. Petersburg. You were rather optimistic in describing the picture because of the implementation of this program. Your predecessors and I were always arguing about it because I always ask them, when you provide some assessments, some numbers about the situation in our country, please ask us. Speaking about the red color, when we are one of the regions, I can also argue with you about the content because 34 million are tested. 34 million of our citizens tested for HIV. I don't think that African regions and other also have the same numbers, but you're talking about our region as the region which is lagging behind. That's why I would like to discuss these issues, even within the framework of this conference later on, about these numbers concerning Russia. And thank you very much. Somehow I also didn't like that idea of yours that men don't like to be treated, but we need to educate them. That's our fault. We need to educate them. We need to raise them in taking care of their health. And also circumcision, you said that it was sort of a new thing in contamination or decontamination, but even if you remember the Old Testament, it was already mentioned as a prevention measure, as the measure of prophylaxis, because that was done in order to avoid infections even back then, especially sexual infections. When we decide the human genome and when we discovered the deepest secrets of nature, we started suddenly thinking about the new discovery, circumcision. No, probably. I want to apologize before the speakers, but I want you to understand that we have a time limit, and Alexei Tsoi, due to some circumstances that make him leave us earlier, he asks us to give floor to us. So, Alexei Tsoi, the Deputy Health Minister of Kazakhstan, will give him floor. Esteemed ladies and gentlemen, stopping the epidemic of AIDS is one of the goals for 2030 in the world. In order to implement the political declaration of the United Nations, UNAIDS developed the global strategy about how to end the spread of this epidemic and achieve the goal of 1990. Kazakhstan is actively participating in this program. We also aim at this goal 1990 because in Kazakhstan we have 26,000 people living with HIV, or officially registered over 20,000, which HIV testing is possible. People have access to that, and we test over 2 million people, which accounts for 10% of our population. The policy of HIV testing allowed us to increase the awareness of HIV up to 80%. It means that 80% of the HIV-infected people know about their status. We also introduce express testing for HIV, mobile testing labs, and we can test the key sections of populations in order to cover the HIV-infected people. We use WHO recommendations for RT therapy and other recommendations. And as the result of these measures, 55% of the HIV-infected people receive the treatment or virus suppressed. In 2005, only 5 regions provided therapy to the people. Later on, 10 regions were covered. We increased the state funding for this effort, and we buy all the necessary drugs only from the government budget. Now we have the clinical and treatment protocols in compliance with the WHO recommendations, and we have covered a long path, and we have achieved great success in RT. We buy drugs through UNICEF at prices which are twice as low, or sometimes 40 times as low as the market prices in Kazakhstan. Since the prices were so low, we managed to use the new combination preparations, and now they cover 14,740 patients who need treatment. We provide medical care for HIV-infected people, and we see the continuous reduction of morbidity in Kazakhstan. The implementation of the testing program and treatment is also accompanied by prophylaxis in the key groups. We implemented 9 out of 13 recommendations of the WHO, and the rest are being implemented. The key sections of the populations are covered, that are covered in the recommendations, allowed us to keep the spread of this infection. Kazakhstan is only 0.2%, shows the 0.2% spread. The most acute problem in Kazakhstan is providing the health care to the migrant, because we don't have visas, and the migrants can travel freely, but there are tight connections between the countries, and the labor migration is very high, and that's why the measures to prevent TB, HIV, and other infections are failing. Only the coordination of all the efforts of all the involved countries can curb this situation, can stop it at the level of migrants. In Kazakhstan, foreign citizens are covered by medical care, for medical care, and those who live in Kazakhstan receive equal medical care, the full package of medical care, as well as the citizens. And those who are temporary residents of the country also covered by the laws of Kazakhstan. We don't prevent the foreign citizens to come to our country based on their HIV positive status, and we use the global fund finances to provide health care for them. And we also established a new program of treating TB in labor migrants. We also signed agreements on trans-border control for TB and other infections. We think that the same needs to be developed for the HIV infected migrants with participation of all the stakeholders, including Russia. We also joined the UNAIDS initiative about the acceleration of this activity in major cities. The president signed the Paris Declaration for HIV ending, and the prophylaxis of infections locally is going on. Use of human potential in larger cities can assure a more fair and equal future, irrespective of the sex, or gender, race, and sex orientation. We support all sorts of activities to improve the situation in HIV infections, morbidity, and we are aiming at stopping the spread of HIV infection in 2030 in compliance with the Paris Declaration. In order to achieve the goals of the WHO political declaration to stop the spread of HIV, we developed by 2030, we developed a roadmap, and the key directions are the perfecting of our algorithm of testing, receiving the certificate of elimination of the vertical transmission of disease from mother to child, and also wide coverage of the general population with prophylactic work. We have an ambitious goal for 2025. We want to have a higher number than 80% of the HIV-infected people status. 70 of them would receive ART, and 70% would receive the viral suppression. We continue our efforts to suppress the epidemic of HIV, and we think that our goals are well substantiated and achievable in spite of the economic difficulties in the latest years, because it is comparable to the situation with stopping the spread of the plague epidemic. And it's a great honor to me to invite all of you to the conference to commemorate the 40th anniversary. The conference will be in October 2018 in Astana. Together with our global partners, we hope for the disease-free future. Thank you very much, Alexei. It was a very good presentation. So I hope that you are leaving, but you're leaving yourself, but you're leaving somebody behind. You mentioned some cooperation between the countries, and you mentioned labor migration. That's a very urgent issue. This document that you developed, can we have access to it? Yes, we can send it to you, because all the countries, with the exception of Kazakhstan, all the countries are hugely represented as labor migrants in our country. And thank you very much for the Almaty conference. I didn't even hope that you'll mention it, because it's a great achievement of our past cooperation. It has a huge potential as far as prophylaxis, or the primary prophylaxis, because I remember Nur Sultan about 10 years ago. He analyzed the situation, and he very sharply analyzed the situation, and he restored some of the measures, because sometimes some measures were almost completely eliminated. Thank you very much. Now the floor is given to Mr. Gottfried Hönschel, who is the director of HIV and Hepatitis Department, WHO.
Mr. Schenko, and many thanks to the organizers and specifically the government of the Russian Federation for inviting me and WHO to speak here. I hope you are not too hypoglycemic yet and can still listen to me. I will focus on the 1990, so testing treatment primarily, even so I will also touch on some of the prevention elements in the context of universal health coverage. My presentation builds and expands obviously on previous speakers and also on the remarks that Ren Minghui has made in the opening ceremony today. So let me start out with a quote by Dr. Tedros, the Director General of WHO, who is a champion of UHC. He says, "We have a historic opportunity to make transformational improvement in world health. Let us make universal health coverage a reality for many more people." And he doesn't explicitly mention people with HIV, hepatitis, or TB, but of course they are included there. In that spirit, I would like to address three critical issues. First, how far have we come, and what will it take to achieve 1990? And it's about 2.5 years left until 2020, and as an important milestone towards ending AIDS. The second question, building on some of the very positive experiences, but what are some concrete opportunities for scale-up? Doing the same over and over will not get us there. So the role of innovation is an important one. And I just want to mention some examples of innovation in my presentation. And last, how can the HIV response be best positioned within universal health coverage, UHC as I refer to it? And how can UHC actually help us to achieve the HIV target? So let me start with a global picture, and Dr. Popova has shown that, and you know the figures, but I just want to highlight, out of those close to 37 million people with HIV, about 5 million actually are co-infected with hepatitis B or C. And TB, as has already been said, takes an important toll on the mortality as well. But an additional point I want to make is 1.8 million new infection and 1 million people still dying with the tools that we have at hand. It simply is unacceptable. Overall, we have diverse epidemics. On this slide, you see in which population transmission primarily occurs. Focusing on Eastern Europe and Central Asia, the large light blue circle are persons who inject drugs, and this is then followed by MSM, sex workers, prisoners, and to a lesser degree in young women, many of which are probably partners of drug injectors. Migrants play an increasingly important role in the European context. And understanding the transmission dynamics is critical to have a focused and an effective response that will also have to address the barriers that people face, of course. It's important to recognize that there's considerable overlap across these groups, so people don't often have just one characteristic, and that there's a certain degree of bridging, of course, as has been said already earlier, into the general population. So let me start with the global cascade, and it's already been shown. What has been the progress in 2016? Of the 37 million, 70% knew their status, 53% were in ART, and 44% were virally suppressed. One could argue not so bad, and we should really be able to fill these gaps, and the gaps are the gray, the numbers in the gray bars on top. But this was the global picture. So let us look at different parts of the world. And here you see the cascades in different WHO regions. Some regions are doing better than others. The African cascade on the very left and the European cascade are actually quite comparable. The American cascade is the best, and the Eastern Mediterranean, so close to the European one, is clearly falling behind with very low treatment coverage and what is referred to as a treatment crisis. So let us look at the European region more closely and disaggregate by sub-region. Western Central Europe in red and Eastern Europe and Central Asia in blue. And here we see quite a big difference. High knowledge rate of HIV, over 85%, with good linkage to treatment, and 65% virally suppressed. It is likely, I would argue, that Western Central Europe would reach the 1990 targets in 2020. Eastern Europe and Central Asia, in contrast, quite a different story. Considerably lower first 90 at 63%, and a major gap between the first and the second 90. Many people who know their status are not able to access treatment. Only about 1 in 3 of all persons living with HIV are on treatment, and only about 20% are virally suppressed, which will also have a major impact on prevention, because it means that 4 out of 5 people may actually continue to transmit the virus. This has already been shown. Just to highlight again, the HIV epidemic keeps rising at an alarming pace in the European region, and again 80% in the eastern part. Half of the people, 51%, with HIV in the European region are diagnosed late, meaning treatment is also delayed, and there's an increased risk of comorbidities like TB and ultimately risk of death. It will be so important to diagnose people earlier, not when they get sick, and also to link them to treatment as quickly as possible. Let us have a closer look at persons who inject drugs, to see how they are able to access treatment, again, in different parts of the world. On this slide are proportions of drug injectors with HIV on the ART. Very high access rates, 89%, in Western Europe, North America, and Australia. Considerably lower in most of Asia on the left, and very low at less than 1% in Eastern Europe and Central Asia. And this is from a Lancet study published in 2016. I have already mentioned the important role of TB, but let me also have a look at hepatitis C HIV co-infections. As you probably know, since about 4 years, there exist highly effective oral drugs, they call the DAAs, direct-acting antivirals, to cure HCV in a period of 8 to 12 weeks. People with HIV-HCV co-infection, however, are known to progress to cirrhosis, liver cancer, and end-stage liver disease much faster than those who are mono-infected with HCV. On this slide, you see the co-infection rates in different populations in different parts of the world. The take-home message here is that overall, in a general adult population, co-infection rate is likely to be up to 15%. It is higher in MSM, and in drug injectors, it is 82% globally. Therefore, it is imperative that HCV treatment is included into the intervention package for all HIV-positive persons urgently, with specific attention for persons who inject drugs. We know that there's a major difference in the cascade between non-injectors and persons who inject drugs. Look at the cascades. In blue, non-injectors. In red, people who inject drugs. Considerably lower in all steps of the cascade. And this is data from 3 Central Asian republics. At the same time, we have evidence that harm reduction services will have a major positive impact on bringing persons to testing, link them to treatment, and achieve good adherence with viral suppression rates of 40%, as shown in the cascade from Ukraine. In red, the clients of harm reduction services, and in blue, non-clients. We see an impressive difference. Also, in a recent study from 5 countries, and they're mentioned on the slide, it was demonstrated that harm reduction services will lead to both epidemic impact on HIV and HCV, as well as cost savings by getting people tested and treated earlier, and obviously saving costs on tertiary care later. So to summarize so far, globally we have seen progress, yet it's uneven in different parts of the world, and there are major challenges in Eastern Europe and Central Asia, as demonstrated by cascade data. People are getting tested late and are not linked to treatment. Less than 1 in 3 persons who are HIV positive are currently on treatment. New infections are rising sharply, so I would argue this calls for a comprehensive response that includes prevention and harm reduction. And unless immediate major scale-up of proven intervention occurs, the 2020 targets are in serious jeopardy. But let me focus on the second question. What are some of the opportunities for scale-up, and particularly those where innovation could play an important role in enhancing access? For each of these innovation areas, by the way, WHO has developed specific guidance and is supporting countries in introducing them. Let me start out with the first 90, testing. In essence, identifying people who are HIV positive so that they are starting treatment immediately. Often, specifically in concentrated epidemic setting, a lot of testing happens, a lot of resources are being spent, yet the positivity rate may be low. We have to turn this around and get testing right. This means increasing efficiency and making sure that those most likely to be positive can access testing and get linked to other services. We know that mass campaigns do not necessarily provide the best yield in such situation and may have limited impact. In addition, we need key population approaches that have higher positivity rates and greater impact, while obviously ensuring confidentiality and informed consent. Concretely, access to testing is often low due to marginalization and stigma, as I think we all know. So tailored approaches are needed that are non-discriminatory and supportive. Couple of examples. Peer outreach has, in many instances, increased reach and uptake. Self-testing, as has been said, as a relatively new method in HIV is now gaining traction and is highly acceptable to clients and could be a very good solution in many settings, specifically for key populations. And partner notification will be an important innovation together with social network testing. If people don't come to services, the services need to come to them. Community-based approaches can reach the unreached and lead to earlier diagnosis. When it comes to the current situation in Europe, many of these innovations I just mentioned are still not used at high levels. To see the box on the right side of the slide, or the part on the right slide. And specifically, self-testing and partner notification can and should be expanded. Self-testing currently is used primarily through CBOs, private pharmacies, and through social networks, with availability increasing in Belarus and Ukraine and possibly other countries. Countries in general still need to get self-testing addressed by policies and have it included into their national programs beyond demonstration projects. So let me move to treatment. A powerful new drug, dolutegravir, an integrase inhibitor, has become available. It is faster acting, it's less toxic, it's more robust, and with the potential to be cheaper in many settings. In fact, modeling studies show that by switching increasingly to dolutegravir over the next 4 years globally, substantial annual savings could be achieved. And countries have started the transition to dolutegravir, and currently about 40% of low and middle income countries are moving and are adjusting their national guidelines to incorporate dolutegravir in first line, which includes actually most of the countries in the European region. WHO supports the transitioning. We are currently updating our guidelines and will release a new version in July at the IES conference to address the dolutegravir in first line. We also support the monitoring of drug toxicity and resistance, it's already been mentioned, and provide advice to countries on transitioning to new drugs, including dolutegravir. There are also exciting innovations in lab monitoring, specifically the use of multiplex diagnostic technology. Some diagnostic technologies can test for multiple diseases, such as TB, HIV early infant diagnosis, HIV viral load, HCV viral load. This can optimize workflow, increase patient access, create efficiencies. It can also help to move towards a more holistic patient approach and service integration, which is so called for. Again, WHO has a guidelines document which is mentioned on this slide. Another area in which innovation could and should occur is in service delivery. Differentiated service delivery has been getting a lot of attention lately. It means, in essence, that different people have different needs. With respect to ART, some patients are stable, some arrive late and have comorbidities, and some have adherence issues. They will need differentiated care. This concept is now being applied to key population, and there's a WHO guidance document. What is the best timing for revisits? Where can people best be reached? Who are the optimal providers? And what additional services may they need in terms of health, but also social services? In essence, it is a one-size-does-not-fit-all approach, where services need to be tailored to effectively reach those most affected populations. And there is also innovation in PrEP. Oral PrEP is in fact not so new. WHO recommends PrEP since 2015, and we have now also released an implementation tool based on the expanding body of experiences by countries. PrEP is an additional intervention in the context of combination prevention and is most effective and appropriate for persons at substantial risks of HIV acquisition. To date, it has primarily been used by high-risk MSM and sex workers in some settings. Persons who inject drugs should not be excluded from PrEP services. It should also not be seen as an alternative, but as an addition to or as part of the harm reduction package, particularly if there is high sexual risk. To date, national rollout of PrEP is at different stages in a number of countries in orange, with some other countries in light orange doing demonstration projects. Uptake in Western Europe has increased with a focus on MSM, as I've said, while it is still very limited in Eastern Europe and Central Asia, which certainly could be viewed as a missed opportunity. To summarize the second area, many of these technical and programmatic interventions still need to be considered and implemented here in this part of the European region. They do certainly have the potential to get countries to achieving 90-90-90 faster and more efficiently. But I would now like to come to the third aspect on how the momentum on UHC could also drive further scale-up of HIV services. UHC is a people-centered approach. Everybody needs to find a place under the umbrella, and different types of services which will also have to reach all people, and they are shown in the umbrella. This has to include community-based services supported through national budgets. UHC is a political opportunity to renegotiate and, in fact, to revolutionize health in broader terms. A call to action was launched by WHO at the UN General Assembly in 2017, and the momentum seems to be picking up strongly. While the focus is on health, it will require cross-sectoral collaboration to be successful, with the health sector being a major driver. A central paradigm in this discussion is to leave no one behind. At the heart of UHC is that all people receive the services they need of sufficient quality without incurring financial hardship. There are three dimensions to this, and you see them depicted in this cube, the small cube actually trying to become a large cube. First, it is about financing and costs. This includes issues like how much is covered, how many resources are made available, how are they allocated, and how costs are being shared. The second dimension is which services are being included and offered in the UHC service packages. And thirdly, it is about populations and locations. Who requires special focus and where geographically are extra efforts needed? In essence, this is very much what the HIV movement over the last 30+ years has been struggling with and continues to aspire to address. And as Dr. Ennis also said in the opening, it was at the core of the Alma-Ata Declaration. One very concrete example of an intervention package is that for key population put forward by WHO. It does include health interventions of proven effectiveness, prevention, testing, treatment for HIV, but also comorbidities and services related to sexual and reproductive health. And it also has to include structural interventions to address supportive legislation, policy, funding, stigma, and violence. All these will clearly require, again, the collaboration with other sectors. I would like to summarize and conclude my presentation with 8 suggestions on the way forward for scaling up the response. First, and this is actually stating the obvious, strong focus on key populations is essential. Ending AIDS will not be possible without addressing the epidemics within key populations and their partners, and you have them up there on the slide. And this is also central in the UHC agenda and will be reinforced there. Second, Known effective interventions have to be brought to scale and have to be included in the UHC package. This may require strong advocacy in some instances and obviously good data to back it up. Third, as alluded to, innovations are needed to increase efficiencies, reach, but also sustainability. Innovations have to move beyond demonstration projects and need to be introduced into policy and programs. Services need to be people-centered and differentiated so that they respond to their needs. High-impact HIV interventions need to be combined with other interventional interventions such as common co-infections, comorbidities, including TB, hepatitis, drug and alcohol dependence, overdose management, mental health. Fifth, barriers to access services need to be addressed. As I said, structural and behavioral interventions need to come alongside health and clinical interventions in the UHC packages. Next, advocacy is needed for increased health budgets and strategic allocations of funding for comprehensive HIV services within this broader UHC package. Investments in frontline health workers and community services to increase reach and address HIV-related stigma will be critical. Community services have been and will continue to play an essential role in reaching specific population. This is also central to UHC and will need to be funded from national budgets. And last, moving forward is a shared challenge. There's immense power through partnerships. Governments will lead, with the NGO sector and civil society having an important role in the response. Global partners need to stay engaged in the region. Please count on WHO as a committed partner. Obviously, we will be doing this in collaboration with others, such as UNH, the Global Fund, and global civil society networks, to name a few. In closing, it certainly needs to be recognized that progress has been made in countries in the region. Overall, it is also clear that significant challenges persist, but also that opportunities exist that can and will be embraced fully and urgently, with the potential towards ending the AIDS epidemic as part of and really building on the momentum of universal health coverage. So thank you very much for listening. I would also like to thank my colleagues who have provided inputs into the presentation. Thank you.
Thank you very much, Mr. Hirnschall, for your very informative presentation, and thank you for the only thing that I would like to point out to. So you are saying that the diagnostics should be paid a lot of attention. By the way, that was part of our strategy, and when we were doing so, we were sort of politically we were saying that that was some certain political cost to do so, but I agree with all the points that you have mentioned. We do have a lot of challenges in front of us, and the point that you mentioned is that we need to primarily work with key populations. This is true. This is absolutely true. As for your proposals, the 8 points that you have mentioned, they are absolutely in line with our understanding, with what we think should be done, and they are part of the draft decisions. Thank you. Thank you for your very informative and well-built presentation. We have only 20 minutes, and we have 2 more speakers. Therefore, without any discrimination, but just to recall that we would not have so much time, I would like to hand over to Mr. Rice, who is co-chairman of AIDS 2018 conference, co-chair, professor of medicine, academic medical center, director of the Netherlands HIV Monitoring Foundation. Netherlands, thank you.
And let me begin by thanking the organizing committee for the kind invitation. As you see, the topic of my presentation is overview of the latest scientific achievements, and this is very difficult to do in 10 minutes. So I'll go very, very quickly. And I decided it's my biased selective view of what was presented at a conference on retroviruses and opportunistic infections just a month ago in Boston. So it's going to be a potpourri. Let me see if I can maybe this way should work. So I think, as we've all heard, reducing HIV incidence is key to our success if we really want to end the epidemic. And I want to focus on a number of examples how combination HIV prevention can work in different settings. And again, it's a selection. So to achieve prevention impact, I think we need to realize that, first of all, of course, it all starts with testing. We need to ensure that people who are test HIV positive are offered appropriate services and ultimately reach an undetectable viral load on treatment and are able to maintain so. At the same time, it's a continuum, because people who test negative but are at risk of HIV infection obviously should be able to access services that make sure that they remain HIV negative, and this is a continuous process. An important comment is that no partial credit can be given to all the different components on the slide. They really all need to go hand in hand, and they need to be appropriately targeted to the people and the key populations, or in a generalized epidemic setting, all people that we are speaking about. And only if we do that will we be able to achieve a decrease in HIV incidence. So here's an example from East Africa, Uganda, the Rakai Community Cohort Study, which reported last year in the New England Journal that when they looked at the combination of sexual behavior trends, antiretroviral therapy, and male circumcision scale-up, as well as changes in population-level viral load suppression, in that region of Uganda, they could show that with the scale-up was shortly thereafter followed by a decrease, a 42% decline in incidence by 2016. The same team at CROI last month showed a more detailed view at the Ugandan fishing community in Rakai, which is a hyper-endemic community for HIV, where they again employed the same services that I told you in the last slide about, and started that in late 2011, and were able to show that they could reach incredible increase in ART coverage, in viral load suppression, coverage increasing from 19 to 81%, suppression increasing from 33 to 78%, which are amazing numbers. And they could also see that improvements occurred across the age range, although you can see that there are discrepancies in the sense that ART coverage was lower in the younger age groups and improved over time. And age disparities were also reduced among women over time, but among men, disparities persisted. And I'm showing you this not for the details, but to highlight, which has been said a number of times, that we really need to know the population that we are aiming at, and we need to tailor our responses to, in an ever more detailed way, to certain populations in certain areas. Here you see a similar slide showing male circumcision coverage, which increased from 39 to 63%, and which improved markedly, for instance, also in the younger age groups over time. And all of this, and this was the key point, of course, led again to a decline in HIV incidence, with a similar reduction seen among men and women, and similar tendencies across age. It also shows that, of course, the work is not done and it's work in progress, which is really true for everything I'm going to show you. So going to another part of the world, this is Getting to Zero in San Francisco, where each of the components that you see on the slide, in fact, had already been implemented in San Francisco before 2014. But what they did in 2014 is really bring all the stakeholders in the city involved in the HIV response together and create a citywide comprehensive program, which included citywide coordinated PrEP program, citywide rapid ART program in the sense of trying to put people on ART the day of diagnosis, and also improving linkage, engagement, and retention in care. And again, they saw success because they saw an over 50% reduction in HIV incidence between 2012 and 2016. Now that's a general figure, but for instance, if you look at the PrEP component and the percent of men having sex with men who were PrEP candidates according to criteria that they had established, and see the number that were currently on PrEP divided by race and ethnicity, you can see that there are disparities. If you look in the different populations, particularly you can see that there was an increase over time in all of them, but if you look on the left in the African American population, they are clearly lagging behind compared to other populations. So again, making the point that you need to target your response. Shifting to the other side of the world, this is Australia, the province of New South Wales in eastern Australia, where again, the epidemic is largely driven by men having sex with men, which is very similar to the epidemic in my own country. And they had an enormous rollout of their PrEP program. And the bottom line of the presentation was that with the rollout of the PrEP program added to everything that they had been doing for many years already, they could see a reduction in recent infections and in incidents. This is a slide from my own city. This is Amsterdam. And what we've been doing also for a number of years now, and realized that Amsterdam is a city which has achieved 90-90-90. So I think the point I want to make is, depending on the setting where you work, 90-90-90 doesn't solve all the problems. We still see new diagnoses every year, too many. I would say one is every diagnosis or every infection, new infection is one too many. So what we did in Amsterdam is also try a comprehensive program, and what the slide shows you is comparing how quickly and at what stage of infection MSM become diagnosed in Amsterdam compared to the rest of the Netherlands. And what you can see in the green circles is that we established, as part of the HIV Transmission Elimination Amsterdam initiative, a communication campaign trying to make men having sex with men aware of the potential symptoms of acute HIV infection, and if they had such symptoms, linking them rapidly to care and to the rapid diagnosis. And what we now see, and it may have to do with the campaign, it may have to do with other things we established, we see that men having sex with men in Amsterdam are being diagnosed at earlier stages of infection than in the rest of the countries. Switching gears, tuberculosis, very briefly, again from CROI, is the use of short-course novel tuberculosis prevention. And this is the BRIEF TB trial, an ACTG trial, which compared in a highly high endemic area in Africa for TB, standard prophylaxis with 9 months of isoniazid to 1 month prophylaxis with rifampicin and isoniazid. And the trial was really aimed to show a non-inferiority, which the team was in fact able to show. There's one caveat I know from the details when you look at the presentation, is that in people with more advanced HIV infection, the numbers of events were higher in those receiving 1 month's prophylaxis. So there's work to be done. But again, an advance that may help in TB prevention. Switching then to antiretroviral therapy, I think what I'll talk about briefly is that our armamentarium expands. We've already heard about the global rollout of integrase inhibitor use, particularly dolutegravir. And with that rollout and with integrase inhibitors, there's been a concern, especially in people with advanced HIV infection, that it might lead to a higher incidence of immune reconstitution inflammatory syndrome, or IRIS. So here's the pipeline, and I think for someone, a clinician who's been in HIV research from the very start of the epidemic and HIV care from the very start of the epidemic, it's always remarkable to see these slides and see the amazing advances that we've made in antiretroviral therapy and developing agents, and it's good to see, you maybe can't see the details on this slide, but it continues to this very day, including, for instance, the development of monoclonal antibodies for treatment and prevention, and also long-acting antiretrovirals that will soon become available and still need to find, of course, their niche and the role that they can play. This is guidelines, the purple across the globe, and the purple shows the preferred initial regimens, the orange shows alternative regimens, and as we just heard, if you look at the bottom, WHO will also soon be switching from orange to purple with respect to integrase inhibitors and particularly dolutegravir, which is then going to be very consistent across the globe. Now, as I said, there have been data presented at CROI last year that with integrase inhibitors, we know, of course, that one of their characteristics is that they drive the viral load down more quickly than other drugs. And the concern was that in the background of advanced infection, maybe this could lead to an increase in iris. And in fact, last year there were 2 cohort studies, one in fact also from the Netherlands, suggesting that maybe the risk of iris was increased with integrase inhibitors. And given that many people, as Gottfried just said, across the world still access antiretroviral therapy at the late stage of infection, this was a concern. I think the data presented at CROI from the REALITY trial, which is a randomized trial, which had standard therapy compared to standard therapy plus raltegravir intensification, was actually quite comforting. Because as you can see, the incidence of fatal and non-fatal iris events was exactly the same in both arms of the trial. The other thing which was interesting, which was part of the REALITY trial, is that enhanced prophylaxis, and I'll show you in a second what that means, actually protected against iris. And this is shown on the next slide. Enhanced prophylaxis, standard prophylaxis with cotrimoxazole. Remember, these were patients with an average CD4 count at start of treatment of around 30 to 40 cells per cubic millimeter. And enhanced prophylaxis was, in addition to cotrimoxazole, these patients received 12 weeks of isoniazid with vitamin B6, 12 weeks of fluconazole, and 5 days of azithromycin, as well as a single dose of albendazole. So in other words, treatments, preventive treatments, targeting various ranges of infections. And interestingly enough, the risk of iris was less in those receiving enhanced prophylaxis. So apologies for switching, but I told you I'd show you a potpourri. The issue of residual inflammation. We know that even with antiretroviral therapy, people on treatment have a degree of residual inflammation, and this has been associated also with long-term outcomes and non-communicable disease complications, such as cardiovascular disease and HIV. So one of the areas of research is whether even during ART we can actually modulate the residual inflammation. So as I said, inflammation associated with cardiovascular disease, cancer, as well as mortality, and also with a range of other non-infectious complications such as bone disease, lung disease, diabetes, neurocognitive decline, frailty. And for those, I think the slides will be made available. There are lots of references on this slide to the literature supporting this. Now, why is this important? This is actually important also outside of HIV, because anti-inflammatory treatment is really being studied big time in the area of cardiovascular disease as a way to reduce cardiovascular disease. So apart from all the lipid-lowering agents, etc., there are people who, because of their high level of inflammation, are at clear risk of cardiovascular disease. And in fact, in the general population, shown on the right side of the slide, the CANTOS trial with canakinumab, which is a monoclonal antibody targeting IL-1 beta, has been demonstrated to reduce cardiovascular events. So I'm talking about clinical events here. And a small trial has been done in HIV, which I'll show you in a minute. And the other big intervention that is being tried is low-dose methotrexate in the general population, the CERT trial, which is still ongoing, and I'll show you just very, very briefly some preliminary data in HIV. So in HIV last year, the group in San Francisco showed that using canakinumab, in fact, you could reduce IL-6, which according to the mechanism of action is what you would expect. And shown on the right, which are FDG PET scans, you can see that the amount of orange, which is exemplary for inflammation in the ascending aorta, is reduced after canakinumab. And the same is true for bone marrow activity. So this is a promising intervention. The downside is it's extremely, extremely expensive, and it's really a question whether it could be used on a large scale. That is different for something like low-dose methotrexate. I think I'm not showing you all the data from CROI. I think there's still a lot of questions with low-dose methotrexate in the context of HIV, but just as proof of concept, using the same FDG PET scanning, in fact, in a subset of individuals enrolled in this trial, what they could see is that indeed low-dose methotrexate reduced arterial inflammation to some extent in HIV. So I think I'm just showing you this because it's an area of research that is opening up. I think there's a long way to go, but it's very interesting that these compounds are being tried both in the context of the general population and in the context of HIV. So lastly, and don't worry, towards an HIV cure, that's very easy because I'm going to tell you to go and listen to Professor Sharon Lewin's talk later in the conference. I think the point I want to make with cure is that I think we are very fortunate, actually since 2010, and partially under the leadership of Nobel laureate Françoise Barré-Sinoussi, that there is a global major research effort going on into HIV cure. I think we still have a way to go. I also think that it will be, just like with ART, the use of combination interventions, and I'm sure that Sharon will bring you totally up to date on what's going on in this area. So I'd like to almost finish with this quote from Nelson Mandela, which is, remember to celebrate milestones. I think we need to celebrate our milestones, but we also very much need to prepare for the road ahead because the job is clearly not done. So with that, that's a bridge to AIDS 2018. I'll now put on my hat of co-chair for AIDS 2018 in Amsterdam. I'm showing you a couple of slides because I'd really like to stress that there has been an effort, a major effort, both from the Dutch government, but also from all my colleagues on the Conference Coordinating Committee, to ensure that at AIDS 2018 we would markedly increase the participation of delegates from the Eastern European and Central Asian region. And I see some of my colleagues, like Michel, on the CCC sitting in the front, Mr. Kazachkin. I think we still have a way to go, but I'm really proud that I think we have achieved what we set out to do. Because there's a clear increase for 2018 of accepted abstracts with content covering this region. There's also a clear increase of abstract presenters from the region. We see an increase in invited speakers from the region across the various sessions of the conference, as well as sessions that cover the region. Importantly, I think also the conference, as you know, since 2004 has the Global Village and Youth Program, which is open to the general public, where again people from across the globe and community groups can make applications to be present in the Global Village. And again, the presence of people and the community in the Global Village will be far greater than at any other international AIDS conference at the Amsterdam conference. And I hope we can keep this up. Scholarships. Without scholarships, many people cannot travel and attend these conferences. And in fact, I don't have the details yet because we haven't even reached out to the people who will receive the scholarships, but there is a 154% increase in scholarships from people from this region. And in addition, there is funds available. Funds have been generated and are made available. And this was an effort of AFU International, which will ensure that, again, 20 invited speakers from the region, additional 20 invited speakers from the region, will be able to come. So I'd finally like to end by acknowledging my colleagues from around the world who were really kind enough to share their latest science and the science presented at CROI. And I think I'd like to end by welcoming you all to Amsterdam and also to state that we really need to, I mean, we see all these figures, we see all these numbers. As we did this morning, we should never forget that it's actual people behind those numbers. And we will never end the AIDS epidemic unless we make sure that the people that we develop the science for are actually able to access and benefit from that science. So thank you very much.
Thank you very much, Mr. Rice. And in my turn, I would like to apologize because you didn't have time to share everything that you have, all your expertise, because of the time deficit. But I hope that during our scientific sessions you'll have an opportunity to do it. And I also wanted to remind you, since you provided an overview of the scientific research, all the world, especially people sitting in this hall, are expecting the creation of the effective vaccine. And I think that the achievements of the synthetic biology can make us optimistic in this direction. Thank you very much again for your presentation. Now the floor is given to Natalia Zhukova, Deputy Health Minister and the Chief Sanitary Doctor of the Republic of Belarus.
Dear colleagues, dear chairman, dear delegates, HIV response. Accounting for the demographic situation in Belarus, and the demographic situation is a natural decrease and aging of population. Therefore, our demographics is one of the priorities in terms of providing national security of Belarus. So this slide shows HIV prevalence in Belarus, and I would like to highlight that we have 19,500 HIV positive people living in Belarus. And the problem that was voiced today at the conference is very topical for us. So the concentration is primarily in the southern part of Belarus and in the central part of Belarus. The General Assembly in June 2016 has prepared a declaration, and Belarus sticks to this declaration. What are the measures that are undertaken? There are different types of packages that are undertaken at the national level, at the international level, and also cooperation with Russia and Rospotrebnadzor. That's the Federal Service for Surveillance of Human Rights. We managed to get to reduced intensity of epidemic propagation in our country and keep it into a certain concentration. We have provided better access of pregnant women and children with HIV to ART. Coverage of pregnant women is more than 98%. HIV positive children are by 100% covered by special formula and other ART-related medications. The Republic of Belarus became the first European country that eliminated HIV and syphilis transmission from mother to child. We have reduced 1.2-fold incidence of HIV among younger groups of 15 to 19 ages and 20 to 24 years. As for 1990 cascade, as of today, I'd like to report that we are trying to get closer to the goal, and I want to highlight that 76% of identified HIV. So 76% of people know their status, but only 53% are covered by therapy, and less than 40% have suppressed a viral load. Therefore, we're facing the objectives, and we need to apply a really comprehensive effort in order to try and reach 2020 goals. Every year, healthcare institutions in our country test more than 1 million people for HIV. Our country provides continuous and equal access to ART to all key populations. So this is universal access to ARVs, and this process also includes 11,000 patients who are kept in penitentiary systems. The dynamics of coverage is growing. Today, Belarus is producing medications which are needed by patients. This is first-line medications. They're all nationally produced in Belarus. Of course, in-country production is a certain guarantee that we will be able to seamlessly provide treatment to our nationals. One of the criteria for sustainable decline of HIV incidence is, of course, prevention and prophylaxis. What we have today in our country, the harm reduction services are covered by 62%, and we believe that the coverage needs to grow. Belarus is actively engaging to development and implementation people who non-governmental organizations. So it's important not only to maintain the experience, but to build it up. Therefore, in 2016, we have developed and implemented the mechanism of federal order, which helps to finance, using federal budget, the harm reduction services. We are actively involving Red Cross and non-governmental organizations. We are also very much concerned about tolerance to HIV-positive people. In Belarus, we have an information strategy which managed to significantly change the mindset in mass media and reduce stigmas and discrimination to HIV-positive people. On top of this, on top of the progress that we have in prevention programs, there is still a number of open issues. We are very much concerned about the growing rate of HIV incidence in the age group of 30 to 34 years, who is the most active part of the society, and therefore we're working on prophylaxis packages that would allow to test those age groups and start treatment at earlier stages. Another important point is keeping or maintaining patients committed to therapies. This retention percentage is 64% now, and we're aimed at 78%. Sustainable Development Goal number 17, partnerships for the goals. In Belarus, we are paying a lot of attention to coordinating effort and joint effort among national bodies and international organizations that are aimed at prevention of HIV. In our country, we have a country coordinating body which helps us to coordinate our effort with the global agencies and work out on national responsive measures to HIV, tuberculosis. This is the national sector, international sector, and non-governmental organizations, religious organizations, and private sector. On our side, we believe that the unified coordinative activity is very important. Therefore, UNAIDS, as one of the leading is playing one of the leading roles, which helps to coordinate our effort and effort of our partners. It also gives us a unique opportunity to apply advanced technologies and experience that has been accumulated in other countries. I would also like to say thanks to Russia for joint scientific research that we're doing in AIDS and HIV area. The achievements that our country has managed to get to in the area of HIV prevention and response is one of the stages only in a long path that we're moving along. Perhaps we're not progressing in all parts and we are having some failures, but we're absolutely convinced that we can do it together with the civil society. And what we need here, commitment to continue therapy, engagement, all the key populations that are still showing risk for for continued development of HIV. We believe that reduction of stigmas will be having positive impact, especially among medical staff. I think that this is one of the growth points which can get us to more positive treatment of the goals that we're faced with, and will help us to reduce propagation of infection in Belarus and our neighboring countries. We remain open, we are prepared for cooperation, and we are very glad for the experience that we're having, for the communication that is being arranged, and we're open for the dialogue. Thank you. Thank you, Natalia. So Natalia has been very optimistic, and she has put an optimistic point in the dialogue that we have. Thank you very much for giving the hope to all of us. Therefore, I would like to close our first plenary session, and I would like to wish all of you be guided by your individual plan, and I wish you having a very productive discussion here. Do not forget about the main topic. So the last day of this conference will be the quintessence of the 3 days work.